Go. Good afternoon, everybody. Thank you for taking the time to join the session. I hope you'll find it informative. And we've got an incredibly experienced panel that we've assembled for you today. Really, the message and the information that we wish to share with you today is a perspective that is probably understated here at the conference. It's a perspective from an industry point of view. And the intent is to share with you a little bit about what's happening behind the scenes in terms of what the initiatives and efforts and investments and resources that organizations are deploying to try and protect information. And we welcome your questions. We would love to foster a dialogue and would love to foster a conversation, but we welcome your questions about really what's happening behind the scenes and in the guts of these organizations as they are challenged with protecting information. The folks on this panel, I'll give them a chance to introduce themselves, but just a quick introduction here. They all represent strong industry experience. They've all had many, many years of experience working in the healthcare industry, working with protecting healthcare information, and unfortunately have spent many a day waking up in the morning with this kind of sense in their gut, what is today going to bring? What new challenges, what new threats, what new exposures? When the email comes in and I open up my computer in the morning, what fire drill am I going to have to put out today that's going to distract me from my overall strategy, my overall mission? Because every day in the healthcare industry brings a new challenge and a new fire drill when it comes to privacy and security. So I'd like to just take a few minutes here just to introduce the panel. Me right here is Leo Dittemore. Leo is the Director of Information Privacy and Security at Healthcare Partners. And Leo really, for this purpose, will be the voice of the provider sector. So Leo will give you a little bit more background about Healthcare Partners and what they do. But essentially, what's about 2,000 physicians?
About 1,500.
About 1,500 physicians. Employed physicians that Leo is responsible for helping those physicians do their job, at the same time, obviously protect information security. Leo is really a traditional computer scientist and has been working in technology and privacy and security for many years. And he's one of those unique individuals that's passionate about privacy, has in-depth knowledge about privacy, but also has the day-to-day experience about how technology works and how security works in a practical way, and the challenges associated with making security work. So thanks, Leo. Appreciate you joining us. On the far end of the table there is Omar Khawaja, and Omar is the CISO for Highmark, a health plan based in the Pennsylvania area. Omar has over 14 years experience in the security field, and before joining Highmark, he worked at Verizon and worked with global clients on their information security initiatives. Omar represents kind of the new generation of information security executives. He brings a deep understanding of security, but he also brings a lot of skills from a business perspective. And I know he's relatively new to his role at Highmark, but his employer brought him in because they see him as somebody that can collaborate with executive peers, with business partners, with members in terms of understanding their needs and making sure that those needs are represented from an information security and protection perspective. And finally, Dr. Karen Bell. Karen is a director at the JBS Center for Sustainable Health and Care. Dr. Bell has had a really impressive career. Everyone's bio is in the handouts. But her career spans roles in the provider, payer, and government sectors. Her leadership roles with CCHIT, and I don't have enough time to go into explaining these acronyms, so hopefully you know what they mean, or you can look them up. But her leadership roles with CCHIT and ONC over the past 10 years have really put her at the forefront of the intersection between technology, healthcare delivery, and security. And so I'm looking forward to hearing her perspectives of the changes she's seen over the past decade. So what I'd like to do is, perhaps, Leo, we could start with you. Can you give us a sense of what a week in the life of an information security leader is all about in your organization? Maybe give us a little bit of background about Healthcare Partners and kind of the scope of your role.
Sure. So Healthcare Partners is sort of a unknown secret in the health industry. As we talked about earlier, we employ about 1,500 doctors directly. Most of those doctors are primary care physicians, and so we operate the doctors' offices. We also contract with another 5,000 to 7,000 affiliated physicians. Those are a mix of about half primary care physicians and half specialists. And so the healthcare partners model is a little bit different. Again, we started in California, and we've now spread to 6 other states, but we are an HMO. And so we think we are the model for value-based medicine. So we assume risks for our patients. We negotiate with our health plans to take on a capitated model for payment per patient per month, and from that payment from the health plans, we operate all of the health care for our patients. So we make money by keeping our patients healthy and out of the hospital. Hospitals being our number one cost. And so that's the model. We're trying to spread that model to other areas. A year and a half ago, we were acquired by DaVita Dialysis, and so we are a wholly owned subsidiary of DaVita now, and looking for ways that we can intersect their patients as well as spread our gospel around the country. So my life as the CISO I spent a lot of time looking at new projects and new acquisitions, trying to figure out what it is we need to do to bring those practices into our operating model. We typically operate our acquisitions as a standalone entity. That means that we've ended up at this point in time with 5 different instances of Allscripts TouchWorks implementations. We've also ended up in the last couple of years with a half dozen implementations of eClinicalWorks. We are in process from one of our acquisitions of transitioning off of Epic onto Allscripts in one of our practices. So we are now looking at how can we simplify our operations and at least standardize, if not centralize, all the computing resources. So I spend a lot of time trying to find ways for people to share data, make sure that they're complying with contracting requirements, make sure we're meeting our compliance requirements. I actually have a dotted line reporting to both our CIO and our Chief Compliance Officer. So I end up trying to wear both those hats to some degree. So I spend a lot of time looking for solutions, making sure that we can operate our systems effectively, and making sure that we are in compliance with our contract and legal requirements.
Great. Thanks, Leo. Leo's coming off a red eye from California, so appreciate you.
Somebody can kick me if I start snoring.
Omar, you represent the health plan side of the equation here, I guess. Can you share with us a little bit about what an average week for you looks like?
Sure. So, like you said, most of my days are seldom planned, or rather, they are planned, but they seldom go the way that my calendar would depict they would go the day before. And every day is different, whether it's a headline that pops up, and if it's a breach. And I used to be on the service provider side when I was at Verizon for 9 years before I joined Highmark. And when I was on that end, we use these opportunities to position other services. And now that I am on the payer side and in charge of actually protecting all of this, anytime there's a breach, it's actually a bad thing, right? It's not a good thing. We get a lot of attention internally. We get a lot of attention externally. And what are we doing to keep our information protected? So there's constant education of our board, of our CEO, of our leadership to say, here's what we're doing. Here's what else we need to be doing. So there's things at that level. We recently went through a CEO transition. So there was a couple of weeks where I was dealing with all the security needs that entail change of leadership. There could be little things. I mean, every now and then I'll get questions that I would never have the right answer to. I got asked, what's our standard for shredding paper? I I don't know. I mean, is it cross-cut? Is it straight cut? You know, what's the width going to be? What's the minimum? I'm like, I don't know. We'll have to figure it out. So it's things as archaic and esoteric as that, which are actually real issues and represent real risk if we don't do it right, to preparing for audits, financial audits of our general controls, to auditing our own suppliers. I mean, there's probably three things that I'm looking at doing as I come into this organization. One is around getting philosophically to a point where security isn't about compliance, right? So a lot of times in regulated organizations, the bar is set at we have to be compliant, and if we're compliant, then we're doing good enough. Unfortunately, the way that information risks are headed today, the compliance regimes, the regulatory requirements are not necessarily commensurate with a sufficient level of control framework to actually protect you against breaches and the cyber risks of today. So adjusting the philosophy to say, compliance is no longer the high bar, compliance is actually the floor, and everything we do on top of that is what becomes increasingly important. So we have to figure out a way to make compliance easy so we can actually redirect efforts on the additional things that will make us more secure and reduce our information-related risk. That's one area. The second area is around supplier risk, right? That becomes more and more important as we move into integrated delivery models, as we embrace the world of ACOs. We probably have a lot more information on our members that's outside our four walls than is within our four walls. Right, certainly because of the High-Tech Act and the Omnibus ruling, we now have a compliance obligation to make sure that we address supplier risk. But even short of the regulatory obligation to do so, there is risk that's represented as a result of our suppliers having information. Now, the business is looking at this. They're looking at things like big data and analytics and saying there's third parties that are popping up that have an amazing ability to take our information, to deliver insights, to revolutionize the way that we do business, to provide better healthcare at a lower cost. And so those are all good things. So as the person responsible for security, I have to figure out how to enable all of those things without getting in the way, without slowing those things down. The last thing that I'm focused on is really one around culture, right? So how does the average employee at Highmark or the average contractor at Highmark, anyone that has access to Highmark systems and member information, how do they think of security? What level of consciousness do they have around security? And it's about a lot more than just awareness. Typically, we think about security awareness. It's a requirement of HIPAA. It's a requirement of most regulations, most industry standards, that you want to do security awareness training, and you do the training, you get the check mark, and you move on. But it's more than just that, right? If you talk to the average employee, they almost always know what the right thing to do is, right? The challenge is not that they're not aware. The challenge really is in creating that energy, in addressing the inertia that causes them to not act according to what the right practice is, right? So they want to stay at status quo. I'm used to circumventing IT controls. I'm used to sending things to my personal email address. I'm used to doing things. How do I continue to do it? So it's explaining to them the impact of what happens if they engage in behavior that's not according to the security policies and security best practices. And if you're looking at why this is important, the one statistic I use and I share internally is, if you look at HHS's data on security breaches and you do the analysis, look at the analysis of how the breaches occurred, in about 50% of cases of the 800 or so that have been reported, in 50% of the cases it was due to user error. Right? So if you think about it that way, then as the person that runs the security department, if I get all the budget, if I hire all the people, if I put all the controls in place, at the end of the day, I'm going to solve about 50% of the security problem, right? So the other half really is with the users, and a lot of that, the bottom line, is culture, and that comes through tying it to our corporate values and things.
Great. Thanks. Dr. Bell, You've seen a lot of changes over the last decade. Have you seen information
How about the
protection
last
efforts? Have you seen information protection efforts evolve over the last decade or so?
Well, I'm actually going to skirt the question a little bit because I think that the bigger issues have to do with not what's happening in the past and what's happening today, but what's happening in the future. And now I understand why I'm sitting between the payer segment and the provider segment, because I think we all recognize that healthcare has been fragmented, and that's actually one of the big problems we've had and why we have trouble with cost and quality and all that other stuff you all know and hear about all the time. And that fragmentation isn't just about fragmentation within the healthcare system, in the delivery system, it's fragmentation between payers and providers. And I'm talking about payers writ large. I'm talking about Medicare, Medicaid, employers, as well as commercial payers. And not only between providers and payers, but also among those groups and community-based organizations. We all know that what we do in the delivery system is maybe only 20% of the overall health of our population. Much more of that's coming external. So we have these great big huge silos. We've got payers who lock up all of their data in one place, and we've got providers who lock it all up in another. And we have all these community-based organizations that have it all on paper someplace, including all those state-based agencies that follow what's happening with housing and jail and all of those other social determinants. And when you really come to the fact that our big vision here is to improve the health of all of us, we have to find some way to bring all of this together, which actually is going to make all of the discussions of my colleagues quite obsolete in a few years, because we're talking now about sharing data in ways that we never even dreamed of before, and frankly, we're not doing today. So as we think about what's just happened in the last few years, we have seen the Affordable Care Act, the Patient Protection Affordable Care Act, completely change or begin to change the model of how we pay for health care. So we're having now far more accountability on the provider side and far less accountability on the payer side with respect to both cost and quality. We unfortunately don't have a whole lot of providers. I think you sound like you do, and I believe you do, Leo, who actually maybe know how to handle risk. But out of the initial 450 or so groups that were taking on financial risk as part of accountable care, half of them have gone under. It takes at least $2.5 million to get started on that endeavor. So we're in this difficult situation right now, transitional situation where the accountability and responsibility for cost and care is going into the delivery system. The delivery system really doesn't know how to handle it very well, and the only real tools they have to do with information. So that's where high tech, the stimulus package, came in 2010 and basically put billions of dollars into the system so the delivery system could begin to have access to that information. The information they have access to is that right now is all clinical. They need claims information because otherwise they can't manage the financial piece. They need, as I said before, information on eligibility and benefit. When I write a prescription for a statin, I want to make sure it's the one that's got the lowest copay, so I know my patient's going to fill it and take it. If it's one of the ones with a $50 copay, they won't even look at it twice. They'll leave it at the pharmacy. So information on eligibility and benefit I'm going to need in this new environment. I mentioned social determinants of health. That's going to be really important. If my patient has become homeless and is living in a motel room somewhere with 5 children, that's important in my care for that patient. So all of these things have to come together. The only way they're going to come together is by freeing up a lot of data that's currently siloed, finding ways to share it, and do so in a very person-centric, patient-centric way. Does this raise flags for privacy? Raises huge flags. I'm not worried so much about security. There are a lot of smart people out there, far smarter than I will ever even pretend to be, who will deal with security.
That's what we think of the privacy people.
But I do think that figuring out that balance between patient safety and privacy is the real big challenge. And that's what I'm putting in front of you right now.
Great. Thank you very much. Leo, as we talk about sharing information, as somebody responsible for protecting the information and really held accountable within your organization for the security of the information, what concerns are presented to you as you're asked to share information either with a state organization, another health plan, or another provider for that matter?
Well, perhaps our example of the accountable care organizations that we belong to might be pertinent to this discussion. So last year, we were members of 6 different ACOs, 3 Pioneer ACO implementations, and then 3 ACO implementations with different health plans. We dropped out of the Pioneer implementations. Why did we drop out? We got into those ACO organizations thinking that we would be able to get all that information that we needed from CMS about each of the individuals. CMS was attributing patients to us that were not informed and not prepared for going into a managed care, coordinated care environment. And then we were told somehow to find out about these patients, get their health information from the hospitals, from whatever clinics they were going to, and somehow help them coordinate their activities. Most of the patients looked at us and said, "Who's healthcare partners and why are you here?" And in many cases, we never even heard anything about them. And so we were not able to make any changes to the healthcare for those patients. We have gone into the ACOs with some of the health plans where we are able to get some information about the patients from the health plan, as well as we've been better organized around talking to the patients about what Healthcare Partners is doing for them and helping them make decisions about their health care. And we are able to show some positive gains, both in the value of the health care they're getting from their different providers, as well as being able to reduce some of the costs associated with some of those patients in those environments. But it is a lot of work. We were unprepared for the work to work directly with CMS at the time. Our history mostly is working with health plans, and so there's some changes on both sides that need to be able to happen, both for people to understand they can share this data or they can't share this data, and making sure that the patients understand the value that we bring to that equation.
Omar, maybe if you don't mind, I'll direct the same question to you. When you're presented with how to open up access to data or sharing data with third parties that you really don't have any control over per se, what does that mean to you? What kind of
Yeah, I mean, so first of all, we've got situations, and I joined Highmark in 5 months, and in the 5 months I've been there, I've seen the worst practice and I've seen the best practice. So the worst practice being we've already entered into an engagement, and now the security team's being brought in to do a risk assessment to say, should we be doing this or not be doing this? And really, the decision has been made, and now we're working on, can we apply some Band-Aids? And we've got much less leverage with that third party to apply additional controls, or even to come in some cases, do audits. But the best case scenario is to be brought in early on. And so we've had several cases where the business has said, we know this represents some risk. We're going to be sharing our customers' PHI. What do we need to do in order to adequately protect this information? And so we do our assessment. We work very closely with the privacy team. We apply things like minimum necessary. Does this information, in fact, need to be shared? So in the case, like there was a case where we were entering into an ACO, and we were about to ship off all of our members' information when we looked at it and we said, do we really need to give them all our members' information, or do we need to just share information for the members that are within that specific geography? So there's certain simple things that we could do to reduce risk. And then a lot of it comes down to validation and testing and making sure that the organization that has been charged with being the custodian of this information, that supplier, has an idea of what good security practices look like, and we're not just putting that into the contract, but we're actually doing some ongoing validation to make sure they're doing that.
I think from our experience, one of the challenges in the industry today is that we're extending access to data at a more rapid rate than we ever have in the past. And for professionals inside organizations, one, just keeping track of who has access to the data, where's the data going, who's it being shared with, that is a formidable task in it of itself, and many organizations just struggle to know where the data is and who has access to that data. And then when the access is actually created, managing that access, particularly when it's an organization that you really don't have insight in terms of their policies and their procedures and who their employees are and how they do background checks on those employees and how they make sure that the access is appropriate. Opening up that kind of access to those kind of organizations becomes a challenge. Not only making sure that access works, but also making sure that access is going to stay secure over time. And I know that's a continuing battle and struggle for the industry. Dr. Bell, what is government's role in all of this? And how does it help and where does it hurt?
It's always a double-edged sword.
Yeah.
One of the a couple of things that I've been doing in the last few years have been associated with the development of what we called an ACO HIT framework. If we are moving into healthcare reform, value-based healthcare, and we certainly look like we're going in that direction because everything we've done until this point in time has failed, so something has to change. And if we're going in that direction, then we really need to understand better what it is these accountable care organizations are going to have to do and what are the IT systems and the information flows that they will need. So I was privileged to essentially pull together a group of very well-known people from around the country to develop and publish this framework. It's publicly available on the CCHIT website, and I can share that with you later. But the interesting thing about it is it was used as the foundation for a lot of discussions of the ACO workgroup. And I don't know if many of you are aware of how the various federal advisory committees work, but there are two big ones. One is the HIT Policy Committee, and the ACO Workgroup was providing recommendations to that policy committee, which would then go on to the federal government. So as a way of answering that question, what these groups have done is to come up with a number of recommendations to the federal government, worked with the federal government to move them forward to support not only a lot of the efforts that are needed in this healthcare reform piece, but also some of the places where another committee, it's always committees with the feds, will have to really look very carefully at the privacy and security. Some of those areas, and I'm going to list a few of them out because I think it's important for you to recognize what's coming down the pike, have to do with access to some of the data we talked about before. Currently, there are 13 states in the country right now that have what are called all-payer claims databases. Massachusetts is the only one where that information is available to any of the risk-taking groups. When I say risk, it's the financial risk-taking groups in Massachusetts. We have 5 pioneer ACOs. They're all successful, and they all have access to this data. But it does provide information to the accountable care organization about all the places and all the costs associated with those places that that patient may have had care outside of the rubric of the accountable care organization. We used to call it leakage. We're calling it keepage now. It sounds a little bit better, more politically correct. So there are issues around that because many patients don't even understand, or many consumers don't even understand their payers have all that information to begin with. And now it's all coming together at a state level and being made available to provider groups. A second area where, again, there's a lot of information that is being shared or could be shared going forward based on our recommendations, has to do with what's happening with behavioral health. Now, I know you just had a discussion about that a little bit earlier today, and I apologize. I had something to do with the School of Public Health in Boston this morning at Harvard, so I missed it. But we have put forth a recommendation that SAMHSA, the Agency for Mental Health and Substance Abuse, provide guidance that would allow an accountable care organization to become what's known as a qualified service organization, so that if you are, like Partners Healthcare in Boston right now, a large organization that has 5 hospitals and a substance abuse center, then there will be some way where critical information that's available in the big EPIC system, the big EHR system that they have there in substance abuse can be made available to at least primary care or coverage groups beyond what's in 42 CFR, because right now the only information you can share clinically is around child neglect and child abuse. So when you think about the patients that are treated, and I just talked with the head of the psychiatry yesterday, John Herman, many of them have alcohol abuse, which means that there's a tremendous amount of comorbidity with respect to liver disease, cardiovascular disease, a number of other things as well. So you really have to integrate that care in order to provide the best care to that patient. So right now there are laws, 42 CFR, that limit the ability to really provide good, safe, patient-centered care. So there is a move afoot, and in fact, on June 11th, there is an open meeting that SAMHSA is having on this very topic about changing 42 CFR, which is the big law that says you cannot exchange information without permission, and defining one specific recipient of that information, so that it might provide better care down the line, particularly in this ACO environment. We talked a little bit about eligibility and benefit information before. There's a recommendation there that that be made available to providers. So in essence, what I'm sharing with you is the fact that in order for us to really focus on healthcare reform, the federal government is probably going to be stepping in and finding ways to make this information that's so critical for patient-centered care within this kind of a new system going forward, and will also be responsible for assuring the privacy and protection rights that go with it. One thing I can share with you on the security side is that, you know, one of the solutions we thought we might consider for particularly around substance abuse and some of the other protected information that occurs, is that it could be sequestered in a system. Right now, and I'm going to pick on EPIC only because I'm very close to the EPIC installation at Partners Healthcare right now, one cannot put information into EPIC and sequester it so it doesn't become part of the larger record. That we thought, well, maybe we would put a certification program in place that would require vendors to be able to sequester information so that if it does go from point A to point B, it would stop there and wouldn't go in the rest of the system, would somehow be redacted out. But in the end, it was felt that while that may be still something that could be happening down the line, it's going to be a long time before we would be able to get to that particular approach. So again, we're going to have to really think very thoughtfully about where and how we will be protecting privacy in this new rubric, because data is being freed up and it's going to be flowing in multiple different ways. And when I say multiple different ways, I think everybody thinks about health information exchange and these big HIEs that maybe work and maybe don't work, probably don't work in most places. But the reality is there's so many other ways you can share information. And while you can't ingest it, for instance, if you're cross-viewing with an Allscripts to an EPIC or a next-gen to eClinical Works, you can at least see it. And in patient care kinds of issues, seeing it and then importing it in another way or entering it in another way creates that kind of a change. So I want to just make sure that when we think about sharing this information, it is electronic, and there are multiple different ways it can be shared. So, you know, putting a fix on a health information exchange isn't going to fix it if you're dealing with cross-viewing or some other types of approaches. So it's going to be very challenging. But the horse is out of the barn. It's happening. So there's going to be a tremendous amount of pressure on how to do this well.
Thank you. One last question for you, Leo. I'll pick on you because you happen to reside in California. But you know, as you deal with both federal agencies and state agencies, you know, how's government helping move forward information protection and privacy in terms of some of the issues you have to deal with, and where is it becoming a hindrance or a problem?
So the problem, I think, mostly is the disjointed way that people think that they can and cannot exchange data. So there are those, we have some standards around, the electronic data exchange of transactions, but we don't really have good standards for exchanging the patient record. Being able to consume the data in such a fashion, even just to be able to view the data, ends up in most cases being just a scanned image of something that somebody can look at and hopefully read. So that becomes part of the issue, I think, where government's been a little bit in the way, or at least not leading us into that standards direction yet.
Exactly, and I'm just going to interrupt 1 second and tell you that's a big recommendation that's coming out too.
Right.
That we really need a lot more semantic interoperability. This transition of care document doesn't do it for
Right.
us.
But I think where they are helping us, especially in the privacy world for me, is to provide some guidance around what's expected, how can we show our compliance programs, the examples for both things like the business associate agreements and the notice of privacy practices and the guidance for us to make sure our programs can be compliant with those rules is helpful for us. Again, part of my discussions with the CFO always is, are we doing more than we need to, and why are we doing more than the guy down the street? And so being able to say that we are in fact in the same boat, we are all doing the same things, and everybody is trying to find ways to assure patient privacy and to ensure the security of the data entrusted to us. We are all playing on the same field. So.
I want to make sure to give the audience a chance to ask any questions of our panel. But before I turn it over, I just want to thank you all for your time. And as I mentioned, I think the industry voice is somewhat of an underrepresented voice here, but I hope you share my sentiment in appreciating healthcare partners, Highmark Health Partners, and their kind of support of this summit, their support of patient privacy rights by allowing their folks to come here and present to you and share with you a little bit about what they do on a day-to-day basis. It represents a commitment that they show towards patient privacy, and we appreciate it. With that, I wanted to turn it over and see if you all had any questions, and we'll go from there.
I'm working on a project for S&I framework called Data Access.
Yes.
As you probably
Yeah.
know. And they have two different models. The first model is a web services model, and it has all the things that are associated with web services like WSDLs and the stuff that gets built in automatically in terms of that particular type of security, SAML, so on and so forth. And then I'm part of a separate subwork group that's using it but repurposing it to use Direct. One of the reasons why we did that was because Direct is mandated in MU2. Everybody should be able to do it, theoretically. They should be able to do it. And they should be able to support a consolidated CDA under MU2 requirements. With that as a given, and then the fact that you could tag that with security labels to segment the data, because on a S-MIME message, which is what Direct uses, certificate, using certificate to encrypt the data, but the header information, all that stuff is in clear. What would you accept if you were to get one of these messages from another provider, assume you're both covered entities? What would be the security concern or risk that you would associate, and what would help you make a decision that says, I will release this data to another covered entity? Bearing in mind that HIPAA requires you to not put any barriers under the simplification rule of doing that. And assuming, too, that they have adequate encryption, and so on and so forth. In other words, what extra stuff do you need to mitigate the risk in your organization that you're now going to release it to somebody who's not a business associate?
Sure. So
Another covered entity, somebody across the
So I'll take just one angle at that. The encryption of data in transit is an important control, but it is almost never a sufficient control. So oftentimes we look at data transfers and we say, hey, it's sent over SSL, it's sent over secure FTP, we have nothing to worry about. Or a lot of organizations use things like Zixmail and some of the other tools out there that'll do secure email. That addresses a very, very small risk, but the larger risks are really left unaddressed simply by that one control. So I would say having SMIME in place to do things like non-repudiation, to know who's actually sending the message, to encrypt the message, that's great, but that only gets you from here to here.
Right.
What happens behind it on the other side, all of that's extremely important.
Right, and that's my question.
Yeah, so I would look at all of that, right? So the data governance issue of what happens once that information gets received on the other side, it's decrypted, where is that copied, who has access to it, how is it shared, how is it destroyed, is it put in the cloud, is it shared with a fourth party downstream? Those would be some of the key questions I'd be looking to answer.
So now, you're going to impose additional requirements on this other covered entity in terms of what they do with the data once they get it?
We're going to want to know what they're doing as far as protecting.
What they do with your data you're providing to them for the.
Correct.
And where is that justified?
No, and I appreciate. Yeah, I think I don't know. Forgive me. We were
Yeah.
trying to maybe dissect this kind of use case a little bit, but speaking for the panel, maybe it's probably too deep,
Yeah.
probably for this. But maybe after this we can take it on. I appreciate it, though. Thank you. Good question, though. Thank you.
So, going back to the privacy issue, it seems like there is an inherent tension between this concept of value-based care and having to move into all other aspects, other social determinants of health, so that we're really sharing data that goes far beyond any of the clinical data, especially if we're talking about patient-centered medical homes or community-integrated homes. There's navigators, it goes into social services, there's all kinds of issues there. And the concept of privacy, ownership of your own data, and consent. I mean, is this making consent a moot point? Is there a place for consent in there anymore?
Great question. Any-
So I think I can address a little bit about, again, from our ACO experience. Again, what we found was in the pioneer efforts was that the patients weren't informed about their consent until they had a healthcare event. And when they showed up at a hospital and the hospital identified that patient as somebody attributed to healthcare partners, now all of a sudden they had to tell the patient why this healthcare partner's doctor was showing up at their bedside. And so the patient wasn't ready for that and wasn't informed that that healthcare partners was being involved in their healthcare. And so that's, I think, part of the privacy effort that needs to happen in letting people know that their data is being shared to some degree, and then they have a role in saying, yes, I want to follow that advice or don't want to follow that advice, and let those third parties know that their data is being shared with them.
And technically, I'd say the mechanisms aren't in place technically today to do a very good job at tracking consents all through the sharing of this data, all through those relationships. There aren't really good technical mechanisms to attach the consents or the withdrawal of consent all through that
The supply
life
chain.
cycle.
The
So,
opportunity to
Yeah.
withdraw consent.
Right.
Exactly.
Because lots of times patients don't even know that they have that.
right, and it's something we have to do a better job addressing from an industry perspective. Our technologies today don't do a great job at capturing that and then passing that along, and essentially applying some rule set based on that information. And so it's definitely a challenge that we're dealing with now.
So is this maybe a place for government?
What I can share with you, I sit on a couple of state HIE organization boards, and consent management is one of the hottest topics that we do at the state level. The degree to which the federal government, I think, wants to get into this is going to be very much dependent on the commitment that it has to support health information exchange going forward. And as I say, there are multiple ways that can be done. But consent management, I think, is currently being developed a lot at the state level with the concept that ultimately some of the better models will be generalizable and be able to be used more on a national level. But it's still in development.
Great question. Anybody else? Any other questions?
There was a study a few months ago suggesting that a lot of ACO patients would go outside the ACO for care, and I wonder whether this can be solved. Karen seems to think that there are things in place to solve this. That is the data interchange problem that is solved. Or will it mean that ACOs have to grow and become bigger monopolies, or will it mean the experiment will fail? I guess those are three possibilities.
There's a fourth. And I steal it from Elliot Fisher, who's essentially the father of, I think, the ACO movement. He tells this little story that if you've got sheep in your pasture and no fence, you better make darn sure your grass is greener than the pasture next door. So I think the reality here is that patients will continue to go where they choose to go. I don't think we're going to go back to the old HMO model where you have to see your primary care doc for everything. I also think that there are huge opportunities to really engage patients better. We've spent years doing things to patients, and I say we meaning docs because I practiced for many years. And when I say doing something to them, I said, here's a prescription, whatever else, go and tell them what to do. In this newer environment where there's a lot more team-based care, patient-centered medical homes, we're actually doing things for patients. We're scheduling appointments for them, following up, make sure that they come in for various and sundry things. But the reality of it is it isn't until we start doing things with them that we're actually going to create that kind of loyalty and stickiness into the delivery system. And I will share with you that most of the large delivery systems that I work with and know of have difficulty with that really incorporating patients in. And when you incorporate them in, privacy becomes not as much of a big issue again because there's more trust, there's more understanding, there's more education involved, and I keep thinking there's 5 things you got to do around culture change. You got to make it simple. I mean, the KISS principle trumps everything else. Then you have to be able to inform and in some cases educate. And then you have to communicate really well. And we don't do that so well either. We do have some secure messaging now. That's not enough. We need a lot more in the way of remote monitoring, telehealth, all of those sorts of things. And then ultimately we do get to collaboration. But that's what I think is going to be the model going forward.
But I think it is establishing that trust as the base for all of this. So just showing up at a patient's bedside and saying, I'm corporate, I'm here to help you, doesn't really set that up.
Try, I'm from the government,
right.
I'm here to help you.
Good question, yeah.
Think of the insurance companies jumping in the bandwagon and setting up wellness institutes and I guess dietary plans and calling up patients and saying, hey, we can get you on this plan. Aren't they practicing medicine without license and everything? And there's no consent there either. I have a big problem with that.
Do you want to take that or shall I take that?
We have no problem with it.
As I said earlier, there has been this huge tectonic shift in terms of responsibility. And most of the large insurers have dealt with it by diversifying. So we have, for instance, Cigna jumping into creating, literally embedding care coordinators in their ACOs. We have United creating big databases. Aetna is creating health information exchanges. And I could go on and on and on. Almost every payer is diversifying to find its way of partnering with ACOs. And I think the degree to which you need that partnering as a provider of care, as a clinician, will determine the degree to which that insurer will participate.
I mean, there's a fine line between them practicing medicine and there's also a question of consent.
Mm-hmm.
So, I mean, it really bothers me. I don't know if there's some moral laws in place that stops that because the Affordable Care Act is kind of pushing these wellness programs and prevention programs to these providers, not the healthcare providers, but the insurance companies are getting the act and doing that. So it makes me uncomfortable. Should my primary care physician tell me if I need to go see a dietitian or what I need to do? Why should an insurance company provide a insurance company call me up and say, oh, by the way, we can set you up for that. First of all, there's no consent there. Second of all, they're practicing medicine without a license. They may have a nurse down the line someplace saying something, but there's, I mean, they should be looking at this.
Well, this has actually been going on for many, many years, and whether it's following up on diabetics or something of that nature, insurance companies have been doing it for years, and so that is nothing new, and it has never been considered practicing medicine. There's always been a very fine line that when you are engaged in these kinds of care coordination activities, you are not practicing medicine. That has been tested multiple times over. But I think the real issue here is that kind of follow-up is going to happen in this new environment, no matter what. It's cohort management, care coordination, whatever you choose to call it. It's going to be happening in this new environment. So the question then becomes, there are some places, some delivery systems, for instance, that do it all themselves. So it stays within the delivery system. There are some groups that work with insurers and have the insurers do it. So I think the issue really comes down to the fact that you do have choice. And there may be, if you're someone who really wants to just stay with a delivery system, then there are primary care physicians who will provide those services themselves. And those are probably the ones you would want to work with.
And
Yeah,
I'm sorry.
no,
so
I understand.
No, we'll hang around. Great question. Thank you very much. Appreciate the question. And the panel will hang around for a few minutes afterwards to address any specific follow-up you may have. But again, thank you for attending the session. Thank you to the panelists for your participation. Really appreciate your time and effort. And enjoy the rest of the summit. Thank you.